Right. Thank you very much, everybody, joining us today. Today, inshallah, will be a combined, as Dr. Rehab mentioned, will be a combined case discussion. And then at the end, in the last 25 minutes, we'll have a quick review and updates on things that are emerging and happening in multiple myeloma. Thank you very much for the attendance, and to Dr. Sameh Gaballa from Moffitt Cancer Center and Dr. Mustafa Al-kawaaz from the University of Louisville Pathology Department, as well as to our presenters from University of Mansoura, as well as South Egypt Cancer Center. إن شاء الله مين هيكون الفيرست برزنتيشن النهارده معنا؟
دكتورة سارة محمد، مدرس مساعد طب الأورام، مركز الأورام جامعة المنصورة. هتبدأ هي معانا. دكتورة سارة.
معاكي ثانية واحدة أعمل شير أهو ثانية واحدة.
تمام، أهلا وسهلا دكتورة سارة، نورتينا.
So we are seeing your
فاتحة الواتساب. يعني قفلي كله بقى يا سارة، الواتساب والماسنجر كله قفلي كله.
باين كده؟
تمام زي الفل.
اتفضل.
الله.
I will present a case of extramedullary plasmacytoma. A case 40 years old male presented by right cervical and right axillary lymphadenopathy 1.5 years ago. The patient has no NEB symptoms, no medical history, no surgical history, no family history, no non-history of any allergies. Initial workup, the patients have done initial CBC, total leukocytic count was 5.4, hemoglobin 8.9, MCV 70, MCH 16, platelets 396, serum creatinine was 1.4, serum calcium 9.4, albumin 4.7, LDH was not available at the baseline. ESR for the first hour was 50, for the second hour 95. Virology was negative for hepatitis C, hepatitis B, and HIV. Radiological, the patients have done like ultrasound and axillary ultrasound, showed multiple enlarged lymph nodes in the posterior triangle of the neck and the right deep cervical lymph node. The largest was 3 cm, mostly malignant. At the contralateral, there was a left deep cervical lymph node, mostly 1 cm. وفي multiple enlarged axillary lymph node, largest 3.5 1.9 cm, impressive malignancy. والcontralateral no left axillary lymph nodes. يعني في multiple cervical lymph nodes, largest on the right side, multiple axillary largest on the right side. Then CT work up multiple cervical lymph nodes, cervical lymph node the largest was a submandibular 4 cm, right supraclavicular, multiple right infraclavicular 3.5 cm, right axillary 3.8, 3.2. The patients have done excisional biopsy of the right axillary lymph node. Diagnosis CD138 was diffuse positive for the neoplastic cells. MBO was focal positive. Ki67 was 70%. MOM1 was positive. But CD20, CD3, and BCL6, CD10, CD30, cyclin D1, CD56, CD79A, CD19, ALK, CK, CD34, CD117, HMB45 were all negative. Kappa and lambda were unfit for interpretation. The final diagnosis was malignant large round cell tumor consistent with plasmacytoma. Please correlate with other clinical and laboratory data to exclude the possibility of multiple myeloma. The patients have done bone marrow aspirate, normocellular, plasma cells 2% with no infiltration, bone marrow biopsy, there was no deposits. The patient repeated the workup once again. Hemoglobin this time was 14, MCV 77, MCH 21, serum creatinine was 1.2. Bone marrow aspirate for the second time was normocellular with plasma cell 1%. Second time, but this time show a plasma cells that constitutes 5 to 10% of the total cellularity confirmed by positivity of CD138. In IBT, there was no any abnormal cells. Serum protein electrophoresis and immunofixation were normal. The patient was treated as a lymphoplasmacytic lymphoma and received the 4 cycles. The cervical lymph nodes decreased to 1 centimeter, with the axillary lymph nodes decreased to 1.7 centimeter. The patient have a marvelous response to the shop, so he continued another 2 cycles. Then he was re-evaluated by PET-CT. PET-CT shows only multiple residual active lymphomatous deposits at the right axillary and the right supraclavicular region, reaching 2 centimeters with SUV 11, where right cervical lymph node was reactive. So the PET-CT showed only 2 active sites, right axillary and right supraclav, reaching 2 centimeters with activity SUV 11. The patient underwent another excisional biopsy for the active lymph node in the PET-CT, which confirmed the same diagnosis: recurrent plasmacytoma in the axillary lymph node confirmed by CD138 positivity. The patient was planned to receive CyBorD, but the expense was refused, so the patient is now on high-dose DEXA. The patients have a differential diagnosis from multiple myeloma. The diagnosis of solitary extramedullary plasmacytoma requires the exclusion of features of multiple myeloma as evidenced by the following. These patients has a normal bone marrow aspirate with no evidence of clonal plasma cells, even if the patients have plasma cells. If it is less than 10%, this is called solitary extramedullary plasmacytoma with minimal bone marrow involvement. If the percent is more than 10%, then it is a multiple myeloma. The PET-CT, the patients have done a PET-CT and didn't show any lytic lesions. The patient doesn't have the criteria of CRAB. In the first CBC, he have anemia, but when we repeat the CBC, hemoglobin was 14. The calcium was within the normal range. Creatinine, when we repeat it, serum creatinine was 1.2. He doesn't have any features of multiple myeloma. Even the bone marrow, the protein electrophoresis was normal. Differential diagnosis from Waldestorm. Waldestorm is a unique clinical pathological entity demonstrating lymphoplasmacytic lymphoma in the bone marrow with an immunoglobulin monoclonal gammopathy in the blood. The patients who have a Waldestorm are presented by symptoms related to the infiltration of the hematopoietic cells and the hematopoietic tissues and the effects of monoclonal gammopathy in the blood. And this patient doesn't have any of these. The patient doesn't have clonal lymphoplasmacytic cells in the bone marrow, and he doesn't have monoclonal band. He has a normal protein electrophoresis and immunofixation. What is your diagnosis for the case? Can the extramedullary plasmacytoma be multiple? What is your recommendation as regards the treatment? Do you recommend using VAD or CyBorD in this case? Dr. Eman, can you comment on the slides?
Okay, Dr. Sara. I will share my screen. Okay, is my screen shown?
Yes.
Okay. As regards the pathology of this case, these are the photos of the H&E that shows there is the effacement of the nodal architecture by nodules of tumor tissue. These nodules are formed of large cells that show abundant eosinophilic cytoplasm and eccentric nuclei. Some of them are أيوة.
تمام يا فندم، كملي اتفضلي.
Okay. The cells have abundant eosinophilic cytoplasm and eccentric nuclei. Some of the nuclei are vesicular. Okay. Here also areas of tumor tissue and necrosis. Here some of the cells show prominent nucleoli. These are the nodules. So this is the morphology of the next lymph node excision biopsy. Shows the same morphology, nodules of tumor tissue, the same cells that have plasmacytoid appearance. Here, some multinucleated giant cells. By the higher power, it shows the morphology of the cells and multinucleated giant cell. And here, it shows atypical mitotic figures. By HC, it shows diffuse positive staining for CD138, focal positivity for myeloperoxidase. Ki67 was positive in about 90% of the tumor cells. CD20 shows only positive staining in the reactive follicles, while it is negative in the nodules of tumor tissue. Also, CD79A, it's positive in the reactive follicles and negative in the tumor tissue. Cytokeratin is negative. CD117 is negative. CD34 is negative. Other markers, but the slides are not available, are also negative. HMB45 was done, and LCA. Okay. All B cell markers also are done and were negative. CD19 also is negative.
دكتور ايمان معلش حضرتك قلتي السي دي 20 كان بوزيتيف ولا نيجاتيف؟
Negative.
CD20
Positive in the reactive follicles.
اوكي. كان في باكس 5؟
No, PAX5 wasn't done.
Were there any stains for any epithelial markers, any
Yes.
additional melanoma markers?
HMB45 and CK only that were done. Also CD79E مفروض يعني expected to be positive in plasmacytoma.
Exactly. So this is my main concern. There is, and with a disclaimer that slides, PowerPoint slides are not would not be sufficient for me, unfortunately, to issue a diagnosis. But there is a question about lineage here. CD138 is a good marker for plasma cells, but it's not a lineage marker. It's positive in a lot of epithelial malignancies. It can be positive in melanomas, in rare cases of melanomas. MUM1 is not a lineage marker. The staining for MPO would be concerning to me, recognizing that MPO is a dirty stain. So I would have done a couple more myeloid markers. I would not call this a lymphoma simply because there are no B-cell lymphoma markers, not a single one. 79A should be preserved. I am concerned that 45 was negative as well. So there needs to be further workup. The only thing that I would consider somewhat specific for a B-plasma cell lineage is a strong staining with kappa lambda, either by immunohistochemistry or by ISH, because you don't expect that to be expressed in epithelial or say a small round blue cell tumor, even though I do recognize that this is a somewhat plasmacytoid looking, and I'm sure you recognize, but there are plenty of non-hematopoietic malignancies that will display plasmacytic morphology.
Yeah. So so I share the same concern. I think I think we should definitely do a little bit more workup to confirm the diagnosis, because it's not a classic presentation for so extramedullary plasmacytomas clinically. Sure, you could have one lesion with with monoclonal plasma cells, but to have it purely in the lymph nodes and multiple sites does not really fit that. The other thing on the differential is obviously lymphoplasmacytic lymphoma or lymphoblastic lymphoma, but again, the pathology here does not fit with that. So, and then the IgM, from my understanding, was negative. So this is not a lymphoplasmacytic lymphoma. Is it a plasmablastic lymphoma? I mean, the CD20 markers were negative, and it doesn't really fit that picture too. I mean, sometimes you could have a diffuse large B-cell lymphoma. That's it could have like plasmacytic differentiation, and the CD138 can be positive, but it also doesn't fit because the rest of the markers, the B-cell markers, yeah. So it's a little bit I'm just concerned about the just pinning the diagnosis before moving forward with management recommendations.
So was there any other studies done, cytogenetics, molecular studies done on this tissue?
No.
Okay.
Sorry, go ahead, Dr. Hegazi.
Go. No, I think you're going on the same direction, so please go.
Yeah, so I'm sure what Dr. Hegazi was going to say next is we need to, what would be really helpful is flow cytometry here, because flow cytometry will have additional markers for plasma cells and B cells. Though out of the entire differential, the only thing that is somewhat of a possibility, and I would still say it's highly unlikely, is what Dr. Sameh mentioned, something like a plasmablastic lymphoma, because those tend to be missing a lot of B markers. Having said that, 79A specifically is usually preserved across the board. And having a loss of 79A, 19, and 45 together somewhat rules it out. I would throw PAX5. I think that would be a good idea. But I would do flow, and I would do a B cell receptor rearrangement by PCR.
Flow on the lymph nodes?
Yes, if you acquire any future, any future fresh tissue. If not, you can actually do PCR on the paraffin sections if there are no upcoming, if there would be no possibility of upcoming sampling. But I would not leave it like this, because there's a big question, and it's a lineage question, and that usually makes me extremely nervous, because you're not talking only about hematopoietic elements. I would also encourage you to throw more melanoma markers. Usually we don't consider HMB45 sufficient, so I would throw in S100 or any available. I would do at least 2 melanoma markers. I would do some keratins. Throw in some keratins. Any of the general lineage markers that would rule out, the main offenders.
Yeah, so flow cytometry is it available at your institution on lymph nodes, or is it only done in bone marrow?
Done on the bone marrow only.
Yeah, that's the problem. Yeah.
We can do it. We can do IBT on a FINAC from a lymph node.
Yeah, I think the flow cytometry would be super helpful, I think.
So the next step to do more IHC markers on the pathology. So?
Yeah, and also look into the molecular part to see if there is any clonal rearrangement there, because we might be. The response to R-CHOP is interesting though, because you had multiple lymph nodes response, except for one, which is the axillary lymph node, right? After R-CHOP for 6 cycles.
CHOP without R.
CHOP without R.
CHOP without R. Yeah, CHOP, sorry. كان في residual on the PET follow completion was a residual lymph node, صح?
Right axillary و right infraclavicular.
Okay. ده اللي هو at the end of treatment. ده مش
Yeah, at the end of the treatment. After
but
6 cycles.
Dr. Hegazi, did we have a staging CT or PET initially? I don't, or was it just like ultrasounds?
CT كان في band CT at the start كان في cervical و axillary contralateral bilateral cervical و right axillary.
Okay. لكن ما فيش حاجة في الابدومن، ما فيش حاجة في
لا ما كانش في أي حاجة في الابدومن خالص. والبيت CT ما كانش في أي finding غير ال right active axillary والintraclavicular.
Yeah. I mean, Dr. Mustafa, يعني could it be like a plasmablastic lymphoma? I mean, you know, what do we need to exclude? I mean, obviously we need a flow cytometry. I mean, that's
B-cell clonality would be very helpful. With plasmablastic lymphoma, you lose plenty of B markers, but you don't lose them all. With the lack of 45, so what was done was 19, 45, which 45 is not a B marker, but it is considered a general hematopoietic marker. So 19, 20, 79A, the only thing that I can think of is PAX5. If all of these are missing, usually with plasmablastic lymphoma, you've got one or two of these markers that are there. So I worry that, you know, we just don't have a B marker to call it a B-cell lymphoma. Is it a possibility? It could be. I mean, there are reportable cases. But I would also stress that we need to do kappa lambda by preferably by in situ hybridization. If it's not available by IHC, I recognize that the IHC is have a lot of background and usually is not super reliable, but we need something to prove lineage, and we don't have anything here. 138 and MUM1 is positive across tumors. And so it's not that helpful. And 138 is not a specific marker either.
And you don't think mid-88 would add, you know, because we're not thinking the lymphoplasmacytic lymphoma possibility is that high on the differential here.
No, lymphoplasmacytic lymphoma, plus I don't recall the last time I've seen a lymphoplasmacytic lymphoma that looked that ugly and had a Ki-67 of 70%. We're talking about a higher grade malignancy. Plus mid-88 is positive in 60% of diffuse large B-cell lymphoma. So if this is a large cell lymphoma, mid-88 is not going to be helpful whether it's positive or negative.
Yeah. Could it be like one of these like spindle cell tumors, carcinomas?
That's exactly what I'm worried about, because those are notorious for having very non-consistent, bizarre phenotype. And the only way to catch these is just by doing ample of immunohistochemistry, you know, just throwing multiple keratins. I wouldn't just do a pan-keratin. I would do a high molecular weight keratin. I would do CAMP 5.2. You know, you can, at this point, I would do things like Desmin, any sort of smooth muscle dash small round blue cell tumor, anything that can look plasmacytic in appearance.
Yeah, and then the other thing is like it's not replacing the whole lymph node. It's like causing, like it's giving it like, you know, like these nodules, right? It's just a little bit not usual to see with lymphomas, right?
Exactly, it's eliciting a response that's pretty interesting, and that is seen. It's somewhat reminiscent of Hodgkin's in, you know, the nodular appearance that I saw, but that can be seen in plenty of round blue cell tumors. So that, again, that's remains to be a concern.
Okay. Very interesting. So as you know, it's hard to recommend a treatment now, Dr. Sara, بسبب ان the diagnosis is unclear. It responded to the anthracyclines, and you know, I won't be surprised that the high dose steroids might keep some control for a little bit, but of course, as you know, they have their own consequences. and toxicity. So أعتقد إن إحنا we need the diagnosis so we can go for the appropriate second line. Plasmacytic differentiation can give you some response, but that's not going to be long-lasting or potentially curative in this case. It is a higher grade, some sort of a malignancy that needs a definitive treatment rather than cyber B.
And Dr. Hegazi, if it's like a small cell tumor or a spindle cell or some kind of melanoma, it will have some kind of response to the anthracyclines too.
Exactly, yeah. Well, which makes it very vague right now. But يعني أعتقد إن إحنا لو if we added some of the additional immunophenotyping as well as the stains اللي دكتور مصطفى بيتكلم عليها, بحيث إن إحنا make sure that we're not looking at a non-lymphoma or a lymphoma, because we really don't have any evidence here aside from the plasmacytic differentiation, because there's no B cell lymphoma markers at all. And then the other thing is that the molecular studies with a PCR. I don't know, was there any immunoglobulin expression at all? Are any of those cells, any specific immunoglobulin expressed?
Patients done immunophenotyping serum protein electrophoresis only. They were negative.
بس على الليمف نود نفسها, على المalignant cells نفسهم, was it expressing any surface immunoglobulins?
I don't think they have done it.
No.
Do you think the patients can have radiotherapy in these only two sites?
هي صعبة, يعني it's hard to recommend this. لأن the treatment, if it is like what we're talking about, a higher grade plasmablastic lymphoma, local treatment is not going to work, and it won't cure this patient. But that's a very difficult call. I don't know what Dr. Gaballa thinks.
Yeah, I don't think we should, move to a treatment without just, confirming the diagnosis. Because I mean, if it's, whatever it is, I mean, the radiotherapy will fix those local issues, but it will pop up elsewhere if it's not, managed systemically. I mean, obviously, if it's some kind of melanoma or something, that again would be just like a local control, but it's not going to fix the problem. Now, is the patient presenting clinically? Is it like fast growing? Is he sick? What's going on with the patient?
Patients now is clinically stable. They have all the lymph nodes decrease in size, and he is on high-dose DEXA only.
Yeah, so plasmablastic lymphoma patients are pretty sick usually, and they're rapidly growing, and but this is it's not really. It doesn't sound like a plasmablastic lymphoma from that presentation. Those are usually very aggressive, kind of like similar to like Burkitt's or aggressive lymphomas. But this one doesn't sound. This sounds like a solid tumor, to be honest with you, clinically. But it's weird. I mean, an extranodal plasmacytoma sure will present, indel-wise too, but then Ki-67 is very high, and if it's just in the lymph nodes only, nothing else. I mean, it's in case reports, but it would be super, super rare. And then as Dr. Mohamed was saying, I mean, you would have some kind of clonality B cells with a flow cytometry, at least to, prove that these are clonal, B cells or plasma cells. And I don't think we have proven clonality right now. So I think we should just dig a little bit into the workup a little bit more.
Okay, we can do a FNAC on the lymph node and do immunophenotyping on it, trying to reach the diagnosis.
Do you have the capability to do a flow on the lymph nodes, flow cytometry?
The clinical pathology doctors is doing some research on this item. I will ask him.
تمام.
تمام يا دكاترة، عشان نلخص الحالة بعد إذنكم، فحضراتكم محتاجين final diagnosis more investigation. فدكتور مصطفى بعد إذن حضرتك إيه الانفستيجيشن اللي يعني حضرتك تريكومند عشان نوصل للدياجنوزز، ومعانا دكتورة إيمان تقول إيه الحاجات الافيلابل والحاجات النوت افيلابل عندنا، لأن إحنا مش كل حاجة برضه افيلابل.
Any additional B markers you have, specifically PAX5 is very reliable. That's one that I would recommend. I would recommend any and all epithelial markers that you have, pan-keratin, a high molecular weight keratin, CAM 5.2, additional melanoma markers, and just general stuff that's not expected to be positive in lymphoid or hematopoietic neoplasms. So things like vimentin, desmin, just try to put a differential diagnosis for lineages, smooth muscle, mesenchymal, epithelial, and just rule that out with at least 2 markers. And that should concurrently go with trying to get that FNA and get flow cytometry on that. As well as if we have a capability that's the next tier to get a PCR for B cell receptor rearrangement. And if you have any capability of sending it out for kappa lambda by ISH, that would be extremely helpful. At this point, I would also throw an EBV on it because if it's EBV positive, then if it's EBV negative, I mean I would not consider plasmablastic because of everything that's positive thus far. I mean, ultimately, and I hope we don't have to rely on that, but I've had that experience with Dr. Hegazi. The ultimate most reliable thing is something like a next-gen sequencing panel or an RNA analysis for tumor of origin. That's what we do when the tumor is just really confusing and we don't know where it's coming from.
تمام دكتورة إيمان، حضرتك عندك أي كومنت عن الحاجات المطلوبة؟
No, I will do more markers. Okay, I will perform ask for more IHC stains. We have PAX5, CK56, S100, vimentin, desmin, and I will repeat the LCA. Okay, CD45.
تمام، وإن شاء الله البورد جاي بإذن الله يكون عندنا فيدباك عن الحاجات دي تكون ظهرت إن شاء الله، وريدسكاس الحالة تاني بإذن الله.
اوكي.
حضراتكم معانا الدكتورة دينا فرحات، resident of medical oncology جامعة المنصورة، عندها second case. ممكن تفضلي عشان الوقت؟
تمام. ازي حضراتكم؟ انا دينا فرحات resident of medical oncology oncology center Mansour University. I will present a case of 57-year-old lady, query refractory non-Hodgkin lymphoma, diffuse large B-cell lymphoma, medical history, lower limb edema, no surgical nor family history. The condition started with abdominal pain. On baseline PET-CT staging, there was above and below diaphragm lymphadenopathy. Some were amalgamated abdominal lymph nodes, largest 19.5 by 13.5 centimeter, SUV max 43, infiltrating third-party duodenum. And there was left thyroid lobe lower pole nodule 1.5 centimeter, SUV max 17. The patient underwent excisional biopsy from axial lymph node. It was non-Hodgkin lymphoma, diffuse large B-cell lymphoma of non-germinal center, positive CD20, BCL6, MUM1, negative CD3, CD10. The patient started with a CHOP protocol, received 8 cycles CHOP plus 2 cycles rituximab, then underwent re-evaluation PAN-CT, neck, chest, abdomen, and pelvis, which showed marked regressive course regarding retroperitoneal lymph nodes amalgamated, now measures about 2 by 1.5 centimeter. Continued one more cycle our CHOP, which was the 9th
till she underwent البيت سي تي. reference here كان 3.2 للهيباتيك اكتيفيتي يعني. كان على مستوى الليمف نودز كانت نيرلي في سي ار، كان الاس يو في ماكس على مستوى الليمف نود 2.8 ولكن كان الوحيد الريميننج اكتيف كان الليفت ثايرويد لوب لور بول نوديول، كان ستيشنري ريجاردنج سايز ولكن الاس يو في ماكس كان 23. البيشنت كونسيدرد زين ان هي ريفراكتوري، ولكن البيشنت كانت ريتشد للتوتال دوز ادريا، فكملت ب سي او بي بلس اتوبوزايد مع ريتوكسيماب. افتر ثيرد سايكل شي اندروينت بيت سي تي ايفالويشن، الريفرنس هنا كان 2.5. كان في عندنا الابدومينال ليمف نودز اللارجست 2.8 versus 2.7 في اللي قبلها. كان الاس يو في هنا عندنا 3 versus 2.8 في اللي قبلها، والريفرنس بتاعنا 2.5. ستيل عندنا الليفت ثايرويد نوديول السايز ستيشنري، الاس يو في هنا كان 11 versus 23 before.
دكتور دينا, was there ever a biopsy في الثايرويد nodule دي? Was it ever biopsied?
هنا لا، ما كانتش بايوبسي.
اوكي.
البيشنت هنا اعتبروها ان هي ستيج 4 نون هودجكن ليمفوما، ان في اباب لوت فريم ليمف نود بلس ان في ليفت ثايرويد نوديول.
بس الثايرويد was never biopsied.
بالظبط. بالظبط يا دكتور، تمام. هو ده اللي حصل بس متاخر شويه. البيشنت كملت على سي او بي بلس ايتوبوزايد، وصلت للفيرست سايكل، زين اندروينت بيت سي تي ري ايفالويشن، كان ستيل في ليفت ثايرويد نوديول 1.4 سنتيمتر، اس يو في ماكس كان 29. هنا بقى عملنا الترا ساوند ايفالويشن، كان في 2 نوديولز في الليفت لوب، one of them كان تايرازي 3 والاذر كان partially solid partially cystic كان تايرازي 2. هنا عملنا ثايرويد بروفايل which was normal. عملنا فاين نيدل اسبيريشن سيتولوجي من ليفت ثايرويد نوديول كان هيموراجيك، عدناه تاني ريبيتد كان بيسيدا 3 كان بيناين. البيشنت اتعرضت برضو هاير ستاف سيرجيكال، يعني اتعمل لها سيرجيكال ريفيرال، ولكن هم بالنسبه لهم هي توايس فيناك كانوا بيناين، وان هي تايرازي 3 فان هي موستلي بيناين، وان هي مش فور اكسجنال بايوبسي او فور مش يعني نوت فور سيرجري. عملنا برضو ريبيت الثايرويد بروفايل كان نورمال، وعملنا لها ثايرويد سكان which revealed cold nodule في الابر بول اوف الليفت لوب. هو يعني المانجمنت هير، ولو هي مبدئيا كانت معروضه علينا يعني لو احنا اعتبرناها ريفراكتوري، والاونلي ليجن اللي موجوده هنا كان الليفت ثايرويد نوديول، لو احنا برضو اعتبرنا ان هو بيناين بعد التو بايوبسيز فان هي كده تبقى ريفراكتوري في سي ار 1، فان هو لو في رول للاوتولوجيك ستيم سيل ترانسبلانت. ولكن احنا لو من الاول هو بيناين يبقى اذا احنا مش معتبرينها ان هي كانت ريفراكتوري من البدايه، يعني هي ممكن في some sort of badly management من البدايه او حاجه يعني. فاهمني؟
تمام. انا ممكن اكومنت هنا. ف هو طبعا يا دينا very good presentation، بس هو في يعني few things احب اعلق عليهم. number one لما انتوا بتقولوا لنا مثلا ال SUV went from X to X. Okay. We don't know if this is remission or not. في لوجانو كرايتيريا بنبص على الدوفل سكور. فالمفروض الراديولوجيست هيبص على الاس يو فيز، الابتيك في الميدياستاينم والابتيك في الليفر اريا. ولو الاس يو في 1 2 3 this is actually remission. If it's 4 or 5 we don't typically switch therapy just based on the PET scan unless it's like unless انتوا شفتوا بقى ال tumor is growing و new sites of disease وكده، يعني it's absolutely progressive disease. بس if it's just if it's responding بس في SUV وفي uptake وفي كده والdual score 4 or 5, the next step is a biopsy before going to the next line of therapy. لأن هي you could biopsy it and it's like a necrotic tissue, it's not active lymphoma, وساعتها المانجمنت is just a watch and wait. فدي number one. فالدوفل scores number one مهمة. Number two, you always consider a biopsy if it's not clear-cut progression. In most of the cases you would need a biopsy. That's number two. Number three, بالنسبة للنمبر of cycles of R-CHOP هو أنا بس a little bit confused. هو العيان أخذ كام cycle of rituximab with the first CHOP?
3 cycles.
3 cycles.
مع 9 cycle CHOP plus 3 cycles rituximab.
9 cycles CHOP؟
هي البيشنت كان هو considered stage 4 على اعتبار ان في above and below diaphragm lymph nodes plus left thyroid nodule اللي كانت active.
هو بستيج 3 لان هو ما يعني احنا عندنا بون مارو بايوبسي ولا لا؟
اعتقد الدكتوره دينا الانترنت سيجنال ضعف شويه لان السكرين برضه is froze. بس يعني I'm 100% in agreement with you. اللي هو اللي هو after 8 cycles من شاب، وانا ما اعرفش بصراحه ال H when was the time I gave 8 cycles of CHOP. بس that PET scan لو رحنا على البرزنتيشن وقفنا عنده، البيت سكان ده في حد ذاته isn't an evidence of refractory disease because the uptake outside of the thyroid nodule, the uptake is very small and it's really close to the liver uptake. So it wouldn't be a Doval 4 or higher. It's a Doval 2 or maybe 3. I don't know.
ما عندناش الاس يو فيز في الليفر والميدياستاينم قد ايه برضه؟
ما كان did I misunderstand it? I thought if we can, Dr. Dina, if you can share with us the presentation again, or I can actually find it on my email. Yeah. Okay, read.
Maybe I missed it. بس هو لو الابتيك اقل من الليفر لا don't do anything يعني no more chemo, nothing is necessary. هو في liver
ده كان البيز لاين بيت سي تي، ولكن الريفالويشن كان الريفرنس اللي هو الهيباتيك اكتيفيتي 3.2 كان على مستوى الليمف نودز كانت في سي ار كومبليت ريميشن، ولكن كانت الاونلي اكتف او اللي هي يعني الريزيدوال هنا كان الثيرويد نوديول كان اللي هي الاس يو في بتاعها 23، لكن الباقيين الليمف نودز كانت بيلو الليفر بيلو الهيباتيك اكتيفيتي.
دلوقتي انا فهمت. خلاص ساعتها يا دينا كان
يعني هي كانت البيشنت بتاعتنا في سي ار.
تمام بالظبط كده. العينه دي كانت في سي ار. لو انت شاكك ايه اللي بيحصل، لو شاكك يعني طبعا شفت حاجه اس يو في 23 في الثايرويد. The next step at that point was to biopsy that thyroid. Okay. If it comes back negative, don't do anything. The patient is in remission. You're good. Nothing necessary is needed. لو طبعا طلعت ليمفوما لا يبقى ده refractory lymphoma ومحتاج salvage therapy. Salvage therapy I would not have picked up COP, you know, because انت كل اللي غيرته الاتوبوسايد. لو محتاج salvage therapy لا في مثلا جاموكس، في ايس، في رايس، في ديهاب، دي دي بي، وبعد كده لو دخلوا في remission بتعمل autologous transplant. لكن at this point your patient does not need any further. I mean he does. I mean you just need to get another. I would stop doing the PET scans at this point. Just get CT scans of the chest, abdomen, pelvis every 6 months for 2 years, and then stop. And if there's no new lesions, it's not growing, you don't need to do anything.
تمام. يعني recommendation here in patient to start follow up.
تمام.
كده.
بالظبط. يعني ما فيش يعني الايفيدنس بعد اللي هي ال8 سايكل لما شفنا البيت سي تي سكان ده كان خلاص prove الثايرويد نودجل، والثايرويد نودجل was it sounded very unlikely صح؟ لما تشوفها 23 uptake in that one spot and everything else is in a CR هي questionable right there. I agree مع السيرجيكال باثولوجيست قصدي السيرجيكال اونكولوجيست ان مش محتاجين نعمل اكتر من كده للثايرويد برضه for the time being. So I agree. Active surveillance.
الحاجة الثانية برضو اللي أحب أعمل عليها comment هي النمبر of cycles of RCHAP. هو 8 cycles is not 6 cycles is not inferior to 8 cycles, and this has been shown multiple times. The standard of care for frontline diffuse large B-cell lymphoma for stage 3 or 4 is 6 cycles RCHAP. Any more than that, you're not going to get any benefit. You might just get toxicity. But this is number 1. Number 2 is if it's stage 1 or 2 لا يعني ممكن تعمل 3 cycles وبعدين irradiation أو ممكن تعمل حتى دلوقتي 4 cycles of RCHAP without radiation. But there is no really there's no added benefit from 8 cycles of RCHAP.
اوكي دكتور تمام شكرا.
Did they look into whether this is double hit or double expressor profile? I didn't see it, but
yeah, I didn't see a fish. You're right. Was there fish done على lymph node, دكتورة دينا؟
No.
هو طبعا ده بيفرق prognostically مش يعني طبعا المشكله ان هي الدبل هيت ليمفوما ما لهاش ستاندرد. يعني our current standard is R-EPOCH, which is just an additional etoposide and it's given infusion over 5 days. ولكن it has not been tested head to head in double hit lymphoma compared to RCHAP. في طبعا الالينس ترايل compared randomized trial RCHAP versus R-EPOCH upfront randomized, and there was no difference, but it was all comers. It was not just double hit. Most recently for last ASH there was a retrospective large study that looked at RCHAP versus R-EPOCH for double hit lymphoma, and it was actually the same. But it's usually those are biased because sometimes clinically when patients are not that aggressive they would get RCHAP or but when they're more aggressive they got R-EPOCH. So it's retrospective, so it's not really good evidence, but the standard right now for double hit is R-EPOCH. So if you have a presentation with bulky adenopathy like this, high SUV uptakes, high LDH, high Ki-67, it's behaving very aggressive, it's always a good idea it's standard to get CMYC, BCL2, BCL6 by FISH, because if it's a double hit lymphoma, you would need to go to R-EPOCH based on what we're doing right now, not based on randomized trial. طبعا في الحالة دي it doesn't matter because the patient got R-CHOP, went into remission, but maybe for future cases.
اوكي دكتور. اوكي شكرا.
تمام شكرا جزيلا يا دكتورة دينا. شكرا يا دكاترة. يتفضل دكتور محمد بعد إذن حضرتك المحاضرة دلوقتي إن شاء الله.
ان شاء الله لو عندكم وقت وحابين تسمعوا دكتور سامح طبعا ودكتور مصطفى. I truly appreciate you and appreciate your time. It's up to you guys if you want to attend this lecture or not. بس دكتور سامح has offered ان هو ان شاء الله يعني will give a talk على diffuse large B-cell lymphoma sometime in January. We'll arrange it اللي هو تبقى برضه نعمل discussion في كام كيس وبعد كده short discussion على ال standards as well as updates هناك، وساعتها هيبقى في ال new ASH updates كمان جاية، ف it might be interesting to everyone to attend إن شاء الله. Let me share my screen. لو ممكن مش عارف دكتورة دينا are you sharing screen؟ لو ممكن بس to stop the share so I can share my file. Okay. So let's see. Alright, so النهارده إن شاء الله هنتكلم على هنعمل quick review. So early in their training residents will have some benefit from this as well, and then updates for those who have good experience with multiple myeloma and the new therapies that have been recently approved in it. I have no conflict of interest as it pertains to multiple myeloma. As you know, multiple myeloma is the primary malignancy of the most common primary malignancy of the bone, and it's more prevalent in elder men and more in African Americans, at least in the U.S. The data until 2016, it's in my mind is a little bit outdated. Very few patients who actually die within 5 years now. So 52% 5-year survival is for until 2015. There's so many therapies that has emerged since then that has impacted the overall survival of a myeloma patient. I typically tell my patients now that we are talking about a 12 to 15 years overall survival. By gender and amongst different ethnicities, the incidence of new cases per 100,000 persons is broken down here, and you'll always see the higher prevalence in men, as well as the higher prevalence in African Americans or Blacks. Okay, so early in training oncology residents, of course, the most common presentation is back pain. أغلب المرضى بيقولنا that's their complaint, and CRAB criteria has been for a very long time an identifier of disease with the hypercalcemias, the renal dysfunction, anemia, and the bone involvement. دلوقتي طبعا في حاجات زياده زادت على كده. So even without the CRAB criteria, الليكتشر دي انا عاده بديها للفيلوز عندنا. So even without the CRAB criteria, I tell them that's when you become a fellow. Now you know that you diagnose things without the things that you learned when you were a medical student. So من غير ده, without a CRAB criteria, you can have a bone marrow with 60% or more plasma cells, or if you have a free light chain ratio that is over 100. If kappa is involved, or less than 0.1 if lambda is involved, then involvement on focal involvement of the with the lesions that is 5 millimeters or more by an MRI or a PET scan would also diagnose an active myeloma in absence of any evidence to support CRAB. Now, a high-risk smoldering myeloma is a topic of interest between amongst the myeloma people. They're trying to attack the disease early, and Mayo Clinic. High-risk smoldering myeloma has the Mayo Clinic came up with this with 2 or more of these factors of 2. So an M protein more than 2 grams, or a plasma cells more than 20% in the marrow, or free light chain ratio of more than 20 or less than 0.5. 0.05 would still make it a high-risk smoldering myeloma, and for that there's already published data for using some therapy as a preemptive approach to prevent or delay to active myeloma, and the other thing is there are clinical trials with the use of more than just lenalidomide as a maintenance therapy in those patients. Just a little bit of an idea about the pathophysiology and how those patients develop. The bone involvement is a cytokine mediated with the activation of rank ligand, which we do use to help the bone with certain therapies. And that's how the myeloma actually activates the development of these lesions, but also it can affect the kidneys by the monoclonal protein itself directly, and then it can lead to the development of other symptoms in this disease, including amyloidosis and other light chain depositions. The patients are rendered immunocompromised in myeloma because of the dysfunctional immunoglobulin production, and then they are more susceptible to infections. So a simple workup also for earlier in training, you'll look at their CVC or CMP. You always want to get an SPEP with immune fixation, and then you get your free light chains. Immunoglobulins is another good marker to get an idea about the extent of the production. Urine protein electrophoresis is something that I don't always do, and I'll admit that, because the free light chains has been very, very sensitive in picking up what the SPEP doesn't pick. So unless I have a concern and I don't have an abnormality on the serum protein or the free light chains, I would go to the urine. And also on the clinical trials, I have to use the urine protein electrophoresis. Bone marrow biopsy and aspirate is important. Now, it's always been the standard of care to do a skeletal survey. We are more and more doing more than the skeletal survey for those patients because how less sensitive is skeletal survey. And also, we get a lot of patients who come in with abnormal gammopathies because the tests are being done now by non-hematologists quite often, especially nephrologists, and then you end up with abnormalities. And in order to make sure that you don't have a real disease hiding in the background, I don't tend to settle with a skeletal survey. I typically do a whole body MRI for the diagnosis, and then if I'm worried about extramedullary involvement by myeloma down the road, I can always do a PET CT scan. But for the initial workup, I typically go for a whole body MRI. And this is what you would see on the SPEP to identify in the GABA chain and how the M spike would look. And that's how those plasma cells look. And that's what the X-rays would see, those punched out lesions. Now, Mayo Clinic between Bob and Raj Kumar has made myeloma be like one of their biggest strengths as a transplant program, and they had some standards and guidelines that I tend to follow because of their the strength of their studies and all. So they break it down simply based on FISH and genetics to high risk and standard risk, but then they are getting a little fancy with a double hit myeloma, calling it 2 high risk genetic abnormalities, would call it a double hit, and triple hit would be 3 or more high risk genetic abnormalities. Does it really change your management? Not yet. It doesn't. Naming double hit or triple hit doesn't necessarily change our management, but a high risk disease does affect some of the choices that we make in their management, and we'll talk about this in a little bit. So now, this is about the smoldering myeloma and the use of single agent lenalidomide versus observation, and what was the benefit in those. And you can see that mostly the benefit in the use of single agent lenalidomide at a dose of 25 milligrams day 1 through 21 with 7 days off helped your progression-free survival, was significantly different between the two, but it did not really impact other factors, especially if it came to overall survival. Now, the benefit is only in the high-risk group. It does not apply in the other risk groups. So that's something that I typically discuss with the patient. It has its downside, and it's important to have a full conversation about it. Number one is lenalidomide can have its impact, especially if this patient is transplant eligible, on bone marrow and its ability to mobilize. Number two is how long are you going to keep this patient on lenalidomide is another issue, because risk of secondary malignancies with lenalidomide. So it's a conversation of risks and benefits with the patient. I typically do not offer this except in a clinical trial, and we have a clinical trial for that. So I don't just I bring up the topic when there is a consideration of the patient and taking therapy, but I lean towards the clinical trial than just giving based on this data the lenalidomide single agent. Now, as we delve into the more important part, which is our management of the disease, we know that this is incurable, and your management usually includes an induction therapy that puts this patient typically in remission, consolidation to keep them in remission, and then maintenance to maintain that. and the therapies, as you are all familiar, comes with different lines of IMiDs, first, second, and third generations, and then proteasome inhibitors as well. We have those currently those approved 3, steroids, and then monoclonal antibodies. Now there's more than that, but in the front line, outside of cyclophosphamide, there's not much different. Just the difference, the biggest difference is which ones are you going to use in frontline, which combinations. So there is a huge variety of options, and this is for newly diagnosed transplant eligible candidates. What are the therapies that are available with data to support them? So as far if I want to put a blanket statement, VRD as a triplet is still the standard of care and has not been taken down compared to any other of the mentioned therapies. Now, there is some details that to keep in mind. For instance, carfilzomib is with Revlimid and dexamethasone rather than Velcade can be a better therapy in high risk groups. Carfilzomib also is less neurotoxic. So if you have a patient who already comes to you with some sort of diabetic neuropathy, alcoholic neuropathy, or any other neuropathy, it would be a good idea to avoid Velcade or Ninlaro for that matter, and stick to carfilzomib. Sorry, let me go back. Now, quadruplets are leading, and there is data coming up in this ASH about frontline. Not only quadruplets, but quintuplets now. So we are the quadruplets has gotten an approval for VTD DARA. VTD is not a common therapy that we give in frontline transplant eligible patients right now, because we usually use VRD, but the RVD. And with RVD DARA, the FDA has not approved this, but Griffin trial had a significant higher MRD negativity in response. And I will talk about what's the value of MRD negativity in myeloma in a second. Now, KRD DARA is another trial, and elotuzumab, but elotuzumab in our practice has not yet made it that far in early lines of therapy or indications. Isatuximab is just another Me Too CD38 antibody. And then maintenance therapy. So we'll talk about that down the road. So this is a little bit of a diagram about the different therapies and the pathways that we approach. And this is about the clinical trials that are in the making. And BCMA, as you see here in the middle on those cells, is a big marker for CAR T cell therapy now that is already approved in one, and then we have 3 or 4 in waiting to get approved as well. Immunomodulators between thalidomide and lenalidomide and Pomalyst works in various ways to either get the immunity to have a higher level of detection or induced apoptosis in those cells. And then antibodies, as you see, approaching attacking CD38 and CS1. Now, the MSMART is the guidelines, again, of Mayo Clinic in this, and this is for the transplant eligible patients. They break them down this way, and I'll have to say that this is their own take on the double hit and triple hit myeloma, not a standard of care by the rest of the nation by any mean, but standard risk myeloma, RVD, still is the frontline therapy. You collect your stem cells. Now, if a patient, what we do here is after we collect the stem cells, the goal is that now after 4 cycles, we are trying to get the MRD level assessed. And it depends on where we get right there. If we achieve an MRD negativity, there is benefit of waiting on the auto transplant a little further. So the standard has always been 4 cycles. If you are in remission, go for auto and wait on, and then put them on maintenance lenalidomide in the standard group. But in this group, there is also benefit of wait, and there's no significant benefit in those who achieve MRD negativity early on to proceed. And I have to put the disclaimer that this is not a common practice that we I mean, not a common thing to achieve MRD negativity early on. Now, in high risk group, their recommendation is still a quadruplet approach with DARA RVD. This is a point of controversy and not 100% agreement there. In the quadruplet data is still maturing as we go, and it might be the standard of care in the US sometime over the coming few years when the data is completely mature and is clearly has a benefit compared to RVDs. But quadruplet therapy for 4 cycles, auto transplant, and then the preferences in high risk group is to use PI rather than an IMiD as maintenance therapy, and that also applies to the double or triple hit lymphoma. I'm sorry, double or triple hit myeloma. Now, for the transplant ineligible patients, it's a little bit different because you have a longer track of your frontline therapy, that you want to use something that is not very toxic, but also you want to use something that maintains the patient in a good disease control. So if the patient is fit, but still considered for some reason a transplant ineligible. So in our cancer center, we have made a cutoff for 75 years old. That's anybody older than 75 does not is not considered for an auto transplant. Now, age is just a number, right? So we might, me or one of my colleagues, make an argument for doing more than or older than that. But the data and the benefit is pretty limited because with all the available therapies, you know, and the overall survival of those patients outside of the malignancy after that age is you have to put in all that into consideration. Now, RVD light is a regimen that some use in frail who cannot handle triplet therapy very well, and it's kind of a lighter and longer cycles with less lenalidomide. I'm not a huge fan, but there's big proponents there. DARA-REV-DEX, Maya clinical trial that is FDA approved. That's one of my favorite regimens in transplant ineligible elderly populations. Now, doublets we only use in super frail patients who are not candidates for even a triplet therapy, and you have more than one option in those people too. So you know, I have patients in their 80s who are being kept in good control with doublet therapy. Now, a quadruplet comes to still having a role, but we don't use much of the MVP regimen. That is more of a European therapy, and that has been approved along with the DARA in a non-transplant candidates, but we don't do that. And I haven't yet accepted quadruplets at all in transplant ineligible patients. And then maintenance therapy with either lenalidomide. So usually we keep them on a good number of cycles of whatever therapy you pick, either for 8 or 12 cycles, and then you can go to a maintenance therapy, lenalidomide in standard, and then Velcade or Velcade Dex in a high risk dependent. And that's what Mayo's approach. They're basically saying we put everybody on DARA-REV-DEX, but you also can use VRD for, they said 9 cycles, like let's say 8 to 12, and depending on tolerance we stop, or dependent on the plateau of response, we stop once we plateau, and then you maintain the patient, dependent on the risk with either lenalidomide or bortezomib. And this is a little bit of it's a nice, just to give you a visual of the different regimens in myeloma. What are you expecting? And how do they compare to the arms that they were used? It's not fair to compare them to the other clinical trials, but I can just tell you what each one of those at that time therapeutic intervention was evident. And you can, as you can see here, RVD versus like the first one of the very first SWOG 777 was the RVD versus RD, so triplet versus doublet. Put that question to rest with the difference in median progression-free survival of over 13 months difference there. The overall survival difference is not going to be achieved in those because you're still going to go for other therapies down the road. That's the RVD versus RD. You can see here the difference. Now, RVD light, this is a single arm study that just shows you that RVD light is a study with an 86%, is a regimen with 86% overall response rate, and it has about 35 months of progression-free survival. As I mentioned earlier, I'm not a huge fan of RVD light. If I don't think a patient can get standard RVD, I give them RD and go, because the differences is not significant amongst the two. Now, the addition of quadruplet therapy comes. Is there a question? Okay, so the addition of quadruplet therapy versus triplets. This is a study from Europe where quadruplet therapy, as you see, has made the addition of daratumumab, the monoclonal antibody, has made a big increase here, almost a double of the progression-free survival. And that now, again, this is a study of a regimen that we don't use as a standard here in the US. So it might have made a difference over there more than it did here. Maya is, again, the DARA-RevDex study that I've mentioned earlier in the transplant ineligible, and that's my go-to regimen in the elderly, frail population with a newly diagnosed multiple myeloma who are not transplant candidates. As you can see here, after following the patient for those patients for I think a year and a half, 36 months with the median follow-up, there was no, the progression-free survival was not reached in the experimental arm, but it was 34 in the RD. And that's why I look at RD as an inferior, but not super different from RVD light in my mind. And then ixazomib RD versus RD is another study, and again, it's an attempt to get the drugs in further in earlier lines of therapy approval, but hasn't made a huge impact in the management of our patients currently, or at least my patients personally. Now, let's talk a little bit about measurable or minimal residual disease as a goal of therapy. As you see, quite a bit of those newer therapies with quadruplets and now quintuplets are coming, talking about how important is measurable residual disease. And I'm not going to go about the controversy and the discussion of which measurable residual disease test is the way to go. We currently are using the next-gen sequencing with clonoSEQ, but in these studies that has been coming for quite some time now, for at least the past 4 or 5 years, has been the work of, is MRD a goal, and does it make a difference in the patient's clinical outcomes aside from the pathologic response to the treatment, So when you look at this, and I'm sorry for the busy slide, but when you look at the first curve here on the left, between the MRD negative and the MRD positive, it's just the balded colors. So it's the same colors, whether they're transplant eligible, ineligible, or relapse refractory. And you can see here that there is, if you are able to achieve an MRD negativity, there is a big difference between those two groups in the progression-free survival, and you can see that with a rule of thumb. You can fit your thumb between the two curves. That works for me. So that's one thing here that we're looking. But now, does that make a difference in the overall survival? And you can see that over here on the right side in B. In the diagram B, that there is about 20% difference in overall survival at 5 years in those who were newly diagnosed multiple myeloma transplant eligible who achieved MRD negativity, and that's significant. Okay, and then in relapse refractory, that's also another thing, and that, but you have to also look at it in the relapse refractory multiple myeloma. Achieving MRD negativity is such a hard task to get to, but it shows here clinically it makes a difference either in progression-free survival as well as in overall survival, whether that's in a transplant eligible patient or a relapse refractory disease. Now, this is the study of using RVD versus, this is one of the earlier studies that has shown that the benefit of autologous transplant as an approach, and then also the differences in response and the impact of negative MRD by flow cytometry, and take that with a grain of salt compared to next-gen sequencing MRD assessment. And when RVD was used versus the transplant arm, you see there's about a 10% difference in CRs, but there's also a higher incidence of MRD negativity with about 15% more, and that's enough statistically to show that the benefit in the use of autologous stem cell. I think that was just the mic open. So with that, if you look at the MRD assessment and the percentage of patients and where you are, you will see that as the time goes, you're going to lose more patients to MRD positivity, but it's still, again, as you see in the curves between the progression-free survival as well as the percent of patients who maintain their MRD negativity is higher in autologous transplant versus RVD arm. Now, this is the long-term follow-up of lenalidomide, bortezomib, and dexamethasone induction autologous stem cell transplant in comparing both standard risk and high risk. And this is to the point of the benefit of auto transplant in high-risk group. High-risk group is unfortunately the group that is less, on the benefit side when it comes to autologous stem cell transplant. As you see here, the difference in the median progression-free survival is 40 months compared to 76 months in the standard risk. That's a big difference, almost double. And the overall survival, as you see here in the standard risk, it wasn't reached at the end of this study, and they followed for all this time, for all these months, and then overall survival in the high risk group was stopped around 6 years, or a little more than that. Now, this is an interesting study, and I won't take too much time because I know we're way past time, but this is a study of doing a single auto transplant followed by lenalidomide maintenance versus auto transplant followed by RVD consolidation or a second auto transplant. As you can see, the consolidative RVD post-auto and the auto post-auto, like a tandem auto, was not much different, except in the progression-free survival, But in the other, there was no difference in the progression-free survival in the standard risk, which is the ones who usually benefit the most. But the second auto was more beneficial in high-risk group. Have we done that? We have not yet acquired this data in our practice, but that's what this data showed. That's, doing a tandem auto might be beneficial in high-risk groups compared to no benefit in progression-free survival. Now, relapsed multiple myeloma, that's when it gets really confusing, because you have so many drugs that are approved for similar indications, and you don't know which one is which, and you can always look at it as active. If this patient is refractory to lenalidomide and bortezomib, KRG is one. And KRG, what's good about KRG is you're not worried about the neuropathy, as we mentioned earlier, also in frontline. But Dara-Pom-Dex has been my go-to in people who have been refractory to lenalidomide and bortezomib, but I get the daratumumab in right away. Carfilzomib, Pom-Dex is an excellent regimen, don't get me wrong, but I tend to go with the Dara-Pom-Dex as a second line, and especially since I'm not using the Dara upfront yet. And when the Dara upfront comes, there might be a discussion then about using more of the combinations of Dara CAR in second line, Dara carfilzomib Dex in second line. Now you have other approaches you can think of. If somebody who is refractory to proteasome inhibitors, you can use elotuzumab with lenalidomide and dexamethasone. You can also use ixazomib, Ninlaro with lenalidomide and dexamethasone. That's an all-oral regimen, so that's a good thing if you have a patient who has transportation problems. But of course, it's a pill, comes with a big bill. So you have to think about that as well. And then the others are already discussed before. Now in lenalidomide refractory, you always have to go to POM, right? So Pomalyst is going to be your second line. But if you're unable to, and you don't want to use POM, you can use bortezomib if somebody was refractory to single agent to lenalidomide with other combination that did not include bortezomib, which is rare, right? That you would have. Now, in people who have failed all these, lenalidomide, as well as POM, bortezomib, carfilzomib, Dara, refractory, you have a few approvals. Selinexor, which is not a drug that I've used it once since its approval a few years ago, and I don't use it anymore. Belantamab, that's a good drug. I'll talk a little bit about it in a little bit. And then Idacel, that's CAR T cell therapy, and those this CAR T therapy is approved after failure of 4 lines, which typically they are if they are refractory to all these therapies that is in the indication. Now, this is another drug that is not mentioned in the slide before that is also approved in those who have failed multiple and refractory to multiple different melflufen or melphalan flufenamide. It's an aminopeptidase targeted peptide drug conjugate. It's the first of its kind. So what it does is it brings the melphalan intracellularly, and then it ends up getting trapped inside. So it has a higher concentration inside. So that's all. So it's a vehicle to melphalan to get into the cells. There is a higher expression of the peptidases and aminopeptidases in plasma cells, of course, because of their function, making immunoglobulins all the time. But with that being said, they, because it's another melphalan. It's another melphalan that tends to mix with all the other options in people who are at this point. We have melphalan alone with good response, so I have to weigh in the toxicities, the financial toxicities, the actual toxicity to the patient before we give them this new recently approved drug. So I don't use this drug very often. Now, belantamab, on the other hand, is a therapy that I'm using now until I have my hands on the BCMA CARs. But BCMA immunotoxin, so this is a belantamab mafodotin is a drug conjugate to target BCMA. So with that being said, this is an interesting approach. So you're now attacking the same target that you are studying for the CAR T to attack. And of course, this brings up the conundrum of, okay, should I not use that drug if I'm considering this patient for CAR T? And that's possible. You can consider that. But when they studied this, belantamab mafodotin at 2.5 milligram per kilos was the chosen dose, and it was selected because the duration of response was better compared to the higher dose, but also it was more tolerated because of the other toxicities of this drug. Most importantly, the ocular toxicity with keratopathies. And it's a little bit, the response rate is not so much different between 31 overall response rate and 35 overall response rate, so it wasn't enough to make the 3.4 milligrams per kg win this comparison. But it's a thing that we have to keep the ophthalmologists seeing the patient before every cycle, before we give this drug to them, because of the evaluations. They have to evaluate. It has a RIMS program where they have to go in and submit a note that says what grade keratopathy, and if it's anything more than a grade 1, the patient has to hold the treatments and so on and so forth. So it's real toxicity, but it's a good drug in those who have failed a multitude of therapy and haven't, and CAR T is not in their horizon for one reason or another. Now, these are all the current CAR T cell therapies for multiple myeloma that are in the works. The first one is already approved, but it's approved pretty late. It's approved after failure of 4 different lines of treatment. And just to make that clear, if you have a newly diagnosed patient who got RVD and then got an auto transplant and then was put on lenalidomide for a few years, that's all one line. Okay, so until they fail a line, you count it. So with that, this ID-cell is the only one out of all of these approved. And you see here the differences in between them is not limited to just a response. The co-stimulatory domain in these are different, and they are trying to say that which one is less toxic. Even though it has a pretty high toxicity in terms of the all grades, cytokine release syndrome, it has only 5% in grade 3 or more, which is not significantly different from the closest runner towards an approval. Now, with early follow-ups so far in those, you can see that the ID-cell has about a year of median follow-up, and the duration of the response is a little bit short of a year in this. And then now we have the cilta-cel that seems to is promising quite a bit more in those who respond to it. So we have to keep our eyes open for cilta-cel as it's going to make its splash in the near future. And then the other numbers just follow. Now, all of these are through different manufacturers and 2 different centers that are coming up with them. Each center are trying their best to make the win. Unfortunately, CAR T cell therapy is an extremely expensive once commercially available approach, and it makes the healthcare systems very hesitant to use it in a commercial approach because of the reimbursement and the compensations for those is not enough. We are in here in Louisville, we're trying to get our own CAR T through our GMP facility put together, and it's a dual target CAR, so it's a composite CAR, so it's not one target, but this is all in early phases. We're working on getting all our ducks in a row before we get the myeloma protocol started. We have other diseases ahead of it. So with that being said, still cell-to-cell is something that you're going to hear about soon, as ide-cel has already made its entrance, and then we'll talk more about that. Now, the other interesting approach and therapy that is also in the works and might be of benefit in patients who do not tolerate CARs or are not in shape for it, hasn't been yet approved, but bispecific antibodies are another modality, and a pioneer modality that brings in, it's a T-cell engager. And if you guys are familiar with Blincyto or blinatumomab, that's pretty much a similar approach. It's just engaging the target cell to the CD3 cell. So whether that's with teclistamab, which is a BCMA. So again, they are targeting the BCMA, which is one of the most abundant expressed on almost uniformly on myeloma cells. Bring those cells to the CD3 to engage them together and get the effect going. As you see, it's not as of a, the response here is not as impressive in its initial entrance compared to CARs because of the cellular therapeutic approach and how CARs make a difference that way. But what we need to, which we haven't reached yet, is follow up and time on all these products and how much do they actually make a difference in the duration of the response, in the impact of the progression-free survival, and eventually, and these are the therapies in myeloma that overall survival can be significant because you're pushing late in treatment there. These are the lines that you might see that just with time, you will see the difference amongst them. Now, bispecific antibodies are another up and coming therapy that once it proves itself in very late therapies, it will slowly progress to get involved with the earlier, in combination with the earlier already approved therapies, to consolidate the response early on, just like just like how daratumumab did before, and now it's approved in frontline, just how CAR now is trying to compete with an auto transplant. So all these are things that will be coming. Once approved in late therapies, will be coming up to earlier therapies. And that was pretty much it. I kept it short. And sorry, we were all interested in the first case that it took me a little bit to finish. It took us a little bit to finish our two cases. And I'm open to any questions about today's topic.
هو تقريبا مفيش أسئلة يا دكتور محمد. شكرا جزيلا لحضرتك، كانت محاضرة رائعة. تسلم الآيات.
العفو. إن شاء الله يعني لو I can share this PowerPoint presentation with you all إن شاء الله.
تمام، تسلم الآيات يا دكتور محمد. متشكرين، شكرا جزيلا، وشكرا جزيلا دكتور مصطفى ودكتورة إيمان، شرفتونا وكان بورد مفيد جدا ونافع. ربنا ينفع بينا جميعا يا رب إن شاء الله. ننتظر حضراتكم إن شاء الله في تيومر بورد بإذن الله الشهر الجاي. يا ريت حضرتك يا دكتور محمد تبقى تحدده عشان نحضر لو في أي حد عنده حالات يبعتها لنا من دلوقتي،